Honorable Chairperson, respected panelists and distinguished audience, Assalamu alaikum and very good morning. It is great pleasure for me to be here. I'd like to give thanks to organizer to give the opportunity. I'm Dr. Mamun, Junior Consultant of Cardiology. My topic is narrow complex tachycardia, when to consider intervention. Before going to discussion, I'd like to put some scenarios. This is ECG of tachycardia, and in left side there is some wider complex compared to right side, and there is a slight increase of cycle length, that is 350 compared to 320. What will be the ECG diagnosis? A. Atrial tachycardia, B. AVNRT, C. AVRT, D. Atrial fibrillation. And this is an ECG of atrial tachycardia. What is the site of origin of this atrial tachycardia? A. High lateral in the right atrium, high lateral in the left atrium, septal in the left atrium, septal in the right atrium. And scenario 3, 42 years old male with no structural heart disease presented with this ECG. What will be his anticoagulation strategy? A. No anticoagulation. B. Search for having atrial fibrillation. C. Consider anticoagulation after Chadvius score. 4. 45 years old male school bus driver presented with this ECG on his routine checkup with no history of palpitation. What is the next step? A. Assurance and follow-up. B. Oral verapamil. C. Holter monitor Tushar's SVT. D. EP study for risk stratification. Now, discussion. Anatomically, heart is divided into atria and ventricle, but consider with source of the tachycardia, it is divided into supraventricular and ventricular, where in supraventricular bundle of is within the supraventricular region. So, if a tachycardia use the his part in the system, it will be the narrow complex tachycardia, that is within 120 millisecond. So, classification of narrow QRS tachycardia, it may be regular or it may be irregular. In irregular tachycardia, it may be physiological sinus tachycardia or inappropriate sinus tachycardia, SNRT, focal atrial tachycardia, atrial flutter with fixed AV conduction, AVNRT, junctional ectopic tachycardia, orthodromic AVRT, idiopathic VT, especially origin of which is high septal lesion. It may be irregular. In irregular tachycardia, it may be atrial fibrillation, the most commonest one. It may be focal atrial tachycardia or atrial flutter with varying AV block, and it may be multifocal atrial tachycardia. Considering the dependency of the AV node, it may be AV node dependent or AV node independent. AV node dependent tachycardias are AVNRT, AVRT, junctional ectopic tachycardia. AV node independent tachycardias are atrial tachycardia, atrial flutter, atrial fibrillation. Consider the RP interval tachycardia, narrow complex tachycardia divided into long RP tachycardia and short RP tachycardia. If RP interval is more than PR interval, it is long RP tachycardia, and it may be sinus tachycardia, atrial tachycardia, SNRT, permanent junctional reciprocating tachycardia, atypical AVNRT, and non-paroxysmal junctional tachycardia. In short RP tachycardia, it may be typical AVNRT and AVRT, the commonest one. So, all of us are familiar with mechanism of arrhythmias. The three mechanism, with these three mechanism, we can explain almost all the tachycardia, that is re-entry, abnormal automaticity, and after depolarization. So, atrial tachycardia, it may be paroxysmal or incessant. If it is due to re-entry or after depolarization, it causes paroxysmal atrial tachycardia, but incessant tachycardia is caused by abnormal automaticity. Atrial flutter mechanism is re-entry, AVNRT, AVRT also re-entry, but in atrial fibrillation, if it is paroxysmal, the mechanism is abnormal automaticity, but in chronic atrial fibrillation, there may be multiple re-entry circuit. So, here is big 3 of PSVT. PSVT means abrupt onset and abrupt termination. If we take 100% of PSVT, 60% will be AVNRT and 30% will be tachycardia using X-ray pathways, and 10% will be atrial tachycardia. Now, let us go AVNRT, which is caused by dual avinodal physiology. Little anatomy regarding dual avinodal physiology. Here is RO view of heart. This is ventricle and this is atrium, and in between septal leaflet and anterior leaflet there is a ridge where his bundle is located, and atria to the septal leaflet of the tricuspid valve AV node is located. AV node get signal from the atria by two distinct pathway. One is coming from the over the fossa ovalis, which is first pathway, and another is coming of the coronary sinus to the AV node, which is slow pathway. So, in sinus rhythm, impulse coming from the sinus node and goes to the both fast pathway and slow pathway, but slow pathway get found the first pathway refractory, that is why it cannot climb up through the first pathway. But if a critical PAC comes, if it is found the first pathway not refractory, then it climbs up through the first pathway and a re-entry circuit established. So, in that case atria and ventricle activate simultaneously. This is an ECG of a typical AVNRT, where we found that there is a bumping in QRS complex, upward bumping of QRS complex in V1, and also in bumping in inferior leads, which indicates the atrial activation. As atria and ventricle activate simultaneously, that is why POA or atrial activation is just after the QRS complex. It is example of a typical AVNRT. POA may be present within the QRS complex, it may be after QRS complex, immediate after QRS complex, or just distance to the QRS complex, or just immediate before the QRS complex. The most commonest one is within the QRS complex. It may be found before QRS complex when ventricle activation of the ventricle there is some delay. So, common AVNRT, when the anterograde conduction is through the slow pathway and retrograde conduction through the fast pathway. If the anterograde conduction through the fast pathway and retrograde conduction slow pathway, or anterograde conduction slow pathway and retrograde conductions through another second slow pathway, it is uncommon AVNRT. This is the example of ECG of slow fast slow and slow slow. In left panel, we can see the pseudo R and pseudo R in V1 and pseudo S in inferior leads, but in middle panel we see that there is long RP tachycardia, and it is due to fast slow conduction, and in right panel there is P present in between RR complex. It is due to slow conduction. Now, let us go AVRT, which is due to presence of an accessory pathway in between atria to ventricle. If there is presence of accessory pathway, the conduction impulse passes through the AV node and also accessory pathway. As AV node has some decremental property, so the impulse easily pass through the accessory pathway, and that is why PR interval is short. And initial activation of the ventricle is caused by myocardium cell to cell conduction. That is why there is slurring of QRS, initial slurring of QRS, that we call delta wave. So, if the sinus node or a PSC found the accessory pathway refractory, it goes through the AV node, and in the meantime, axillary pathway recover its refractory period, then it goes climb up through the axillary pathway to the atrium, and a reentry circle is established. So by an accessory pathway or arrhythmia in WPW syndrome, there may be three types of arrhythmia. One is orthodromic AVRT, another antidromic AVRT, and another is pre-excited atrial fibrillation. The antidromic and orthodromic AVRT axillary pathway just acts as an integral part of circuit. But in pre-excited atrial fibrillation, this accessory pathway acts as a conduit to pass the atrial activity to the ventricle. This, if the retrograde conduction, if the tachycardia circuit goes through the retrogradely through the axillary pathway, it causes orthodromic AVRT. And the property of the retrograde conduction of the axillary pathway may be faster or may be slower. If the property of the axillary pathway, retrograde conduction of the axillary pathway is slower, it causes permanent junctional reciprocating tachycardia, which is a slower tachycardia, and it is incessant in type. Panel A shows the orthodromic tachycardia using faster axillary pathway, and panel B using the slower axillary pathway, which causes permanent junctional reciprocating tachycardia. And properties of fast axillary pathway and slow axillary pathway: if a tachycardia caused by slow axillary pathway, in ECG we can found long RP tachycardia. And using of atropine isoproterenol exercise causes faster conduction of that slower axillary pathway. And the type of the tachycardia in slow axillary pathway is incessant. And location of the axillary pathway, if it is fast, can be found in anywhere along the atrioventricular ring. If it is slow, it is usually post-receptal. And regarding PJRT, it is sensitive to the exercise, that is during exercise, heart rate or tachycardia rate become more. Now, degree of pre-excitation. As we know that AV node is sensitive to the sympathetic or autonomic system if during exercise, when the sympathetic activity is activated, then AV node conduction of the AV node is faster, and we cannot found the pre-excitation.
2 minutes left.
But during sleep, when the vagal tone is increased, we can found the pre-excitation. Now, atrial tachycardia, as previously we discussed that regarding triggered activity and re-entry, atrial tachycardia are paroxysmal, and abnormal automaticity, it is incessant. It is the example of an paroxysmal atrial tachycardia, sudden onset, sudden offset. This is the example of incessant atrial tachycardia. Now, it is important to know the site of origin before going to cath lab, where is the origin of the atrial tachycardia. To know the origin of the atrial tachycardia, we ask 4 questions: whether it is whether it is from left or right atrium, whether it is superior or inferior part of the atrium, whether it is more laterally located atrium or close to the interatrial septum, or it is posterior or anterior part of the atrium. Regarding left and right, we can get answer from lead 1. If it is positive in lead 1, it comes from the left atrium. If it comes from the lower part of the atrium, there is positive POA in 2-3 ABF. If it is come from the high lateral part of the atrium, POA become wider. If it is from posterior part of the atrium, there is positive POA in view 1. we can see this atrial tachycardia comes from the highlight atrium. That's why negative P wave in lead 1, and there is wider P wave, and there is positive P wave in 2, 3 AVF. This is from highlight atrium, and there is different site of origin of atrial tachycardia. In right atrial tachycardia, the most common site is crista terminalis. Now, atrial flutter, it is also caused by re-entry circuit. It may be clockwise or counterclockwise. The presence of sawtooth appearance is positive or negative sawtooth appearance is depends upon the breakthrough from circuit to the left atrium. In counterclock circuit, the breakthrough occurs lower part of the atrium. That's why there is negative sawtooth appearance, and in clockwise atrial flutter, there is breakthrough occurs in the upper part of the atrium. That's why sawtooth appearance becomes positive. Now, when to consider intervention? Consider to intervention, we should consider whether patient is on in acute condition or chronic condition. If in acute condition, whether patient is hemodynamically stable or unstable. If in chronic condition, whether patient is symptomatic or asymptomatic, or patient symptom is recurrent or not. This is acute therapy of narrow QRS complex. In all tachycardia, if patient is hemodynamically unstable, then cardioversion is the choice. If not, if patient is hemodynamically stable, then we should try drug. In focal atrial tachycardia, atrial flutter, in all case, in acute therapy, the choice is, if patient is hemodynamically unstable, the choice is cardioversion. And if in chronic therapy, if patient is symptomatic and recurrent, the choice is catheter ablation. And if patient is not symptomatic or patient symptom is not recurrent, then drug is the choice. Regarding asymptomatic pre-excitation, we should consider the job of the patient. If patient is a high-risk job, we should consider EP study to risk stratify of the patient. Now the answer of the previous scenario, as there is bundle branch block occur and there is a slight increase in cycle length. It is AVRT, and in atrial flutter we should consider Chadvius score. And as the patient is school bus driver, we should consider EP study for risk stratification. Thank you.